Oh. So how the session is going to run is I'm going to talk a little bit about the theoretical part of pediatric palliative care as an introduction. And then Dr. Lulu is going to have a bunch of very interesting cases, for discussion. I will probably not take more than about 20 minutes. So we have enough time for the cases. And let me see if I can share my screen.
May I interrupt?
All right.
Vanilla, is there a pre-test now?
I just already posted a
You
pre-test
posted it,
and
okay, all right.
yes, the participants have.
All right, thank you.
Do we want to wait for a few minutes for people to finish the pre-test?
Maybe 2 minutes, ma'am. We'll give 2 minutes time.
Okay. All right.
And we can you make your screen a full screen now?
Okay.
Yes, ma'am. Thank you. So another small announcement before we actually start the didactic session by Dr. Manjari. So I request all the participants once again to please rename yourself. And then if it is not, you are not able to do, just put your name in the chat box. We'll rename it for you. It's very, very important to mark your attendance so that we'll know like how many sessions you have attended. And this will make and help us to while issuing the certificate. Also, please mute your microphones when you are not speaking, and please turn on your video cameras throughout the session. It's a humble request. Thank you.
Vanilla, can I interrupt you?
Yes, ma'am,
Everybody
please.
is asking where is the pre-test? Where is the pre-test link?
I posted it in the chat, ma'am. I'll send
please
once
post
again.
it in the chat. Yeah, please
I
post
sent
it
it
in the chat.
I
Yes.
sent now again. I sent it second time.
Okay, please send because many people are joining later on. So
Yeah, posted it again.
yeah. Thank you.
Does anyone still have problem accessing the pre-test questions? Vanilla, I think Dr. Jolly.
Yes, sorry.
Some doctors are unable to join.
Pre-test link is posted in the chat box.
Vanilla, a lot of people are saying they're not able to, they're not getting the access to the, pre-test. What's the way out?
We will just start up the session now because it's already 3:30, close to 3:30. We'll start the session for now.
Okay. So I think while you do have to finish the pre and the post test, let's not get too focused on the pre-test at the moment. I can tell you that the pre and the post test, at least for this session, is the same set of questions. And, it's just for us to get a sense of how well you've been able to really pick up on the information that we've tried to convey. So without much ado, I'm going to try to introduce a little bit around the concept and the principles of pediatric palliative care. Okay, I'm stuck. Sorry. All right. So I'm hoping that, we'll be able to cover some of the basic principles of pediatric palliative care, and then think about some of the disease conditions in children where, these children should have access to palliative care, and to think about what palliative care could look like in terms of if we were to make, that a list of tasks or activities that we do in palliative care for children, what would that look like? And then to think a little bit about what are the levels of palliative care available. I'm going to start with this quote from Dr. Eric Cassell, who I think in many ways was the father of palliative care in North America. He came out with a sentinel article in the New England Journal of Medicine in 1982. It's called The Nature of Suffering and the Goals of Medicine. Later went on to write a book by the same name. And Dr. Cassell says that suffering is experienced by whole persons, not merely by bodies, and has its source in challenges that threaten the intactness of a person as a complex social and psychological being. Suffering can include physical pain, but is by no means limited to it. And therefore, as physicians and clinicians, our role is that the relief of suffering and the cure of disease must be seen as the two twin obligations of a medical profession that is truly dedicated to the care of the sick. And if as physicians we fail to do this, we might, not only fail to relieve our patient's suffering, but in fact add and become a source of suffering to them as well. I just urge you to think about this and reflect on this, in your day-to-day practice. I'm going to talk about some of the commonly used semantics in palliative care for children. So palliative care for kids it's a total and a holistic approach to care. It focuses on the quality of life. We look at all kinds of life-threatening or life-shortening illnesses. So it might be a child who's had a road traffic accident and is really very seriously ill, but could have an almost complete recovery and may no longer need palliative care. It's patient and family centered. So the focus of our care is not just the child, but the whole family around the child. There's a lot of consideration for benefits versus burdens of every single intervention that a child undergoes. The focus is on the goals of care. Why are we doing any intervention? Why are we doing any investigation? What are we likely to achieve? Is there a burden to that intervention that we are recommending? There's a focus on the family. And by the family, we mean not... Did someone put a question mark there? I don't know what's happening. Anyhow. So the family is, it could be the biological family, it could be the extended family, as we are well aware in India. It's very interdisciplinary
Manjari,
in nature
because there is a lag in between your voice. Manjari.
I guess my internet this is at its best.
Savita ma'am, is it the same for you?
Do you want a screen share?
Yes. Just a little lag.
I think I'll do the screen share, ma'am. You can just speak.
Okay.
Yeah.
Okay. Slide 6, Vanilla. Right. So palliative care basically is delivered by interdisciplinary teams. And it doesn't end with the death of a patient. It continues through support for the family through what is called the process of bereavement. Next slide. Next slide, Vanilla. Yeah. This is a very common case that we see in Kuwait because there's a very high incidence of this particular genetic condition. It's what is called marble bone disease. I had never seen it in India. This is a patient that we cared for, a little girl who was 9 months old when we got to see her. This is malignant neonatal osteopetrosis, a very, very severe form of the disease, which is characterized by failure to thrive, very severe developmental delay, very severe bone pain, very severe central neuropathic pain, pancytopenia, frequent respiratory infections, and very brittle bones, which means that they could fracture just by normal handling. When this child came to us, she was having weekly CBCs with frequent transfusions because of bone marrow failure and was requiring frequent IV antibiotics for fever. It was impossible to get an IV line on this girl without possibly hurting her or breaking her bones. The family were very apprehensive about caring for this fragile baby at home and wanted to keep her in hospital. So I'm going to go to the next slide, and I'm going to ask you to think about what are some of the sources of pain and suffering in this child. Vanilla, next slide. So here's what I came up with. This baby who's very small has physical pain. She has severe distress when she's crying. So even a diaper change is terribly painful. She's not really able to verbalize or tell us exactly what's going on or where the pain is coming from. So, she's at a very high risk of being undertreated for her pain. She's constantly crying. She's having frequent medical interventions such as blood draws and transfusions, which are not really prolonging her life and are definitely reducing the quality of life. Okay. We think that these are, futile and very burdensome management. So as the palliative care unit, we actually would do very, very limited investigations. The parents are having issues. So, talking about the family as a whole around the child, it's difficult to care for this child at home. How will they feed her? How will they give her pain meds? What is the cost of the treatment? What does it mean in terms of, does the mom have to take days off work? What about the other siblings? Do the parents feel guilty? Are they being stigmatized for this genetic condition that they might have handed down to their baby? And in the spiritual dimension of suffering, why is it that this has happened to us? Are we guilty of anything? Why our baby? Next slide. So coming then, we talked about one single patient. So that was, I think, a deep dive view at what palliative care at a clinician's, in a clinician's day-to-day life would look like. But then what is the macro view? What is the global view of what palliative care is, who needs it, and what is really out there? So one of the most, the landmark things that happened was in 2017, the Lancet Commission published a global report, which was really an estimate of how much need of palliative care there was in the world. Next slide, please. And what they did was they came up with this term called serious health-related suffering. Okay, which if we just go through the slide, do you want to press enter, Vanilla? So that will tell you what serious health-related suffering is. It's press enter. Yeah, that is associated with an illness or injury. It is so severe that it requires a medical intervention to be relieved. And it comprises not only of physical, but also social, emotional, spiritual suffering. Okay, next slide, please. The global perspective. So what is the need for palliative care? We need to keep pressing enter. So in 2015, 2.5 million children all across the world died with serious health-related suffering. That's more than 1/3 of all the children who died. All of them, virtually all of them, lived in low and middle income countries. And right now, more than 5 million, 6 million are living with serious health-related suffering. So I think globally, the need for palliative care for children is immense. There is no doubt about it. It's just that how do we see that there is a need? And I think it'll become clearer when Dr. Lulu Matthews discusses her cases. Next slide, please. So this was the ICPC estimate of how well palliative care is available for children all across the world. The darker the green, the more developed the services are, which is, across most of the English-speaking and the European regions. India is not doing too badly, but then I think it's because we have quite a lot of training courses such as this one. But in terms of how much service is actually available for children who need it, I think India is greatly lacking. Next slide, please. Let's now come to the definition of palliative care. This is almost my 8th or 9th slide. So what is it? It's an approach that improves the quality of life of patients, adults as well as children, and their families who are facing the problems associated with life-threatening illness. It prevents and relieves suffering through early identification, assessment, and treatment of pain and other problems, whether physical, psychosocial, or spiritual. Next slide, please. Next slide, please. It addresses suffering that involves taking care of issues that are beyond just physical symptoms. Okay, I skipped the previous one, but then that's okay. So palliative care is recognized as one of the human rights to health, and it is very much within, the UN development goals and so on, sustainable development goals. It should be provided through person-centered integrated health services that pay special attention to the specific needs and preferences of individuals. Next slide, please. So, when we go into a ward or into ICUs, this is what it looks like. The clinician is looking at a bunch of investigations, and there's a lot of technology around the patient. And in this cartoon here, the patient, the doctor is not really looking at the patient. He's just looking at the investigations. So what about the whole person? What about the family? What about the non-physical aspects of suffering and so on? Next slide, please. What are the principles of palliative care? It provides relief from pain and other distressing symptoms. It affirms life. So we believe in helping patients and families live as well as possible for as long as possible. But at the same time, it's not death denying. Death is pretty much a part of life, whether it is in children who are severely sick or have conditions that are not compatible with life. So we don't deny death. Death happens. It's a normal physiological process. The care that we provide does not intend to hasten or to postpone death. It integrates psychosocial and spiritual aspects of patient care. It offers families and the patients to a support system to live as actively as possible. Next slide, please. It also supports families after the death of the child, through the emotional responses of grief, depression, and so on, through what is called bereavement care. Palliative care improves the quality of life, and in some cases might actually improve the duration of survival of patients. It's applicable very early on in the course of the illness, as it is throughout the illness trajectory. Next slide, please. What are some of the myths? These are some of the things that we hear all the time. It means that palliative care means that we are giving up hope. It means the patient is definitely dying. Patient has to be terminally ill or at the end of life to receive palliative care. It can be offered only when there's no further disease-directed treatment available, especially for cancers. And once palliative care is offered, the primary treatment care teams are not, to be involved any longer. And that patients will die or lose hope earlier if palliative care is involved. It would be a shock. They'd think that they're dying and they'd actually die earlier. That's not the case. Some of the things are that all families prefer to have end-of-life care at home. And the other big one medically, and I think this is, the doctors are the ones who fear this the most, is that administering opioids causes respiratory depression and death. I promise you it does not, if it is done, under proper guidance with proper knowledge of effects and side effects. Next slide, please. Adults versus palliative care for children. Just as it's adult medicine versus pediatrics, ages and stages are different. The variety of conditions in children where palliative care is applicable is over a few hundred conditions, unlike in adults. We are a society that actually likes to deny that children die because it's just too painful to accept. Kids are not able to self-report. Their autonomy is often contentious. The use of medications is often off-label because there's not enough evidence base around that. Next slide, please. I'm going to talk a little bit about the psychosocial spiritual, which is called total pain. So what is total pain? Total pain is pain that is physical. So this baby that I talked about, Mariam, definitely has pain from very fragile bones, has pain from frequent procedures, but she also perhaps has emotional pain, very poor cognition, but how can she feel the bonding with her mother? How was she ever able to breastfeed? What is the family around her? Emotional pain. What is the social pain? So maybe not so much for the child, but for the family. They have a child that is very severely abnormal, has a lot of suffering and symptom burden and is not going to live. What is the social pain? And then the spiritual, why me? मैंने क्या किया था कि मुझे ये ऐसे हो गया? So those are some of the things that are all encompassing. And why is this important is because all of them actually have feedback mechanisms on the pain pathway. So there is no denying the pathophysiology of pain. Next slide, please. Yeah, we'll skip that. Next slide. These are some of the typical trajectories of how children die. So the first one, either born with a fatal condition, child dies immediately. Is there an opportunity for palliative care? Definitely. This is called perinatal palliative care, where a diagnosis of a fatal condition might be made beforehand. And pal care teams would be involved from even before the birth of the baby. The second one, there's a potentially curable disease such as cancer, but they have ups and downs, and finally they may not survive. So palliative care is applicable. Earlier, the better. The second is, the first one was what I meant by a lethal anomaly. A sudden unexpected death where a child is normal, perhaps could have a road traffic accident or a catastrophic, cranial bleed. So child is well and suddenly drops off the cliff. Possible to have some palliative care, definitely bereavement care. And the fourth one is, conditions where they have a slow decline. So spinomuscular atrophy type 1. I have several patients who are on long-term ventilation having received nusinersen, but their quality of life is sometimes poor, and they often have frequent respiratory infections, which could lead to a dip in their quality of life. Next one, please. These are some of the types of conditions where palliative care is applicable. So life-threatening conditions for which there is some curative treatment, but it could fail. So cancer, certain cardiac anomalies. The second category is where conditions, are life-shortening, but kids could have a fairly good quality of life for several years with a lot of intensive rehab, say cystic fibrosis or certain muscular dystrophies, or HIV on antiretrovirals. Next slide. Then progressive conditions for which there is no cure. So Patton's disease, mucopolysaccharidosis, they have a relentless progression. The fourth is kids who have severe neurological impairment, which means they're always fragile and could be at risk of dying at any time. But these are basically static conditions. So severe cerebral palsy. Next slide, please. Moving on from that, what is some of the language of palliative care? The colors that I've used are, I think, the colors of 2020, which was really about, yes, it was around COVID, where the yellow represented hope and the gray really grounded us to what the reality was. And I think the most important word in palliative care is hope. And you'd probably think, what hope if a child is severely ill, if the child is potentially dying? And what research really found is that if you ask families what is it that they're hoping for, the first thing that they'll say is, we are hoping for a cure. What else are you hoping for? I'm hoping for some kind of a miracle. Thank you for sharing that. What else are you hoping for? And that's when the families might tell you, it might be, hopes that are smaller, that we can work around. It might be that we hope our child's pain is relieved. We can take the child home. Maybe the child is there for their first birthday. The hope that they would be remembered. The hope of finding meaning in this entire experience. So that is hope in palliative care. And I think that is what keeps us ticking. Next slide, please. This is a little bit about how we deliver palliative care. This is called a bow tie model. And it's really about, preparing for the worst while also having some kind of hope. So there's a disease management part, which is really, significant at the beginning and might reduce, whereas a palliative care input increases as the disease progresses. Now, palliative care could include things like pain and symptom management, rehabilitation, hospice, being able to take the child home, end-of-life care, and so on. Next slide, please. When I was talking about the semantics, I talked about the interdisciplinary nature. Now, by interdisciplinary, we mean groups of people from different professions who are working closely together, guided by the goal of what is the best for this child and family. And believe me, the physicians don't really have too much of a role to play. You know, we often have to relegate ourselves into the background and let all these other wonderful people do their work. So I think in my team in Kuwait, the biggest input is from the child life specialists who provide distraction, who provide play, who normalize the environment, who explain procedures to children in languages that they can understand through play, who support families, siblings. And our role there is to really, you know, be able to provide that physical comfort for the child. So manage the pain with treatment, with medications, and then make sure that all these other professionals can come in to do their wonderful bits of work. The picture on the top left, I'm just going to talk a little bit about that, is about memory making. So taking footprints of a baby who could be dying. Next slide, please. So we strongly advocate that palliative care should be integrated in the routine care from the very beginning. And why so? Because as the primary care teams focus on the treatment of the disease, the child will still continue to have symptoms and suffering, and the pal care team is there to look around that. We are able to provide necessary supports for families to cope emotionally, financially, socially, and so on. It's better to have pal care teams integrated earlier on so that when kids become sicker, they don't feel abandoned by the primary team. There is better communication and decision making in all situations. There's an anticipation of what the road ahead could look like. There's better symptom management, and it might potentially increase survival. Next slide, please. So how would pediatricians like to introduce a pal care team to their patients? It could be simply that they are the part of the care for patients with serious illnesses that focuses on things like helping manage symptoms and the stress of serious illness, provides an extra layer of psychosocial support, is able to spend time with patients and families to help them better understand the disease and the treatment options, help the child by managing symptoms, or is simply a part of the routine care. So if any of you go ahead and start palliative care programs in your hospitals, these are probably some of the words that you'll use frequently. And I hope there's many that do that. Next slide, please. Where palliative care, wherever the patient is. So that's Dr. Veronique's team at Wadia Children's Hospital. In the city of Mumbai, it could be the big skyscrapers or the slums provided at home. And the one on the right is this beautiful pediatric hospice in Kuwait. Anywhere where the patient is. Next slide, please. Bereavement care. So we know that grief is a lifelong process, and parents and families never really get over the loss of a child, but that they sort of make meaning of the loss and integrate it in their lives and carry on. Siblings, classmates, friends, extended family, all are recipients of this care. So palliative care does not end with the death of the child. There's a lot of work to be done. Next slide, please. I'm just going to mention this because this is, you know, something that you might want to talk about when you're advocating for palliative care. So there's a basic palliative care approach, which we hope that this course will be able to teach all of you. And this should be a part of care for all children, irrespective of what it is. The second is a general palliative care approach, which is, you know, there is some staff in the hospital or in the institution with some additional training and experience in pal care. And there is specialist palliative care. So people like me who really don't do anything else but pal care full time. And we would probably be doing the complex physical, psychosocial, spiritual aspects of the care and probably be teaching. Next slide, please. I'm going to leave you with this very, very powerful quote. And this is from someone who's called Dame Cicely Saunders. She is considered to be the founder of the modern hospice movement. She was a physician, nurse, and a social worker from London, and she built the first adult hospice in the world, which is called St. Christopher's, which is in London. And she said, "You matter because you are you, and you matter to the end of your life. We will do all we can, not only to help you die peacefully, but also to live until you die." So thank you for your patient hearing. I'm going to hand over to Dr. Matthews. I'm happy to take questions at the end.
Thank you so much, Dr. Manjari, for giving us an overview of pediatric palliative care. Before I hand over to Dr. Lulu Matthews, may I just go over some housekeeping? I know that many of you did not get the pre-test, and that's causing a bit of anxiety. Please don't worry. The pre-test and the post-test questions are exactly the same, and the post-test will be sent to your email IDs, so you will be able to do them. So not to worry. And also those who have done the pre-test, it is not necessary to put it on the chat that you have done it. We will know if you've done it or not. So that's okay. The second point is, if you have any questions like Dr. Naresh did, please do type them in the chat and we will definitely get around and answer them at the end of the session. Many of your phones are still not labeled with your names, and that makes it a bit difficult for us to do attendance. And as you know, we need you to attend 10 out of the 12 sessions to be able to get that certificate. So please do label your phones with your name. Okay. And be reassured again that the post-test will be sent to your email if you're not able to access it on the chat. Now I'd like to hand over to Dr. Lulu Matthews. Thank you so much, madam, and for an interesting practical discussion of pediatric palliative care. Thank you, ma'am.
Shall I share the screen now?
Yes, ma'am. I made you the co-host. You can do it.
Is the screen visible?
No, ma'am. I
Sabita,
can't see
is
your
the screen?
Not yet, ma'am.
No, ma'am.
Not yet?
No, ma'am. Shall I share your slides, ma'am? I'm ready with them.
No.
Yeah, now we can see. Can you just make them
Yes.
full screen, ma'am?
Can you
Just make them full screen, ma'am?
see my slides?
Yes, yes.
We can see, ma'am.
Okay. Okay. Now? Nobody seems to responding. Is it okay now?
Ma'am, it is okay, but if it's full screen, it would be better.
Yeah, I had full screen.
Ma'am, I think you have opened in the brochure, Google.
Shall I share your screen slides, ma'am? Ma'am, you just have to tell next slide and we can start. Over to you. Lulu, ma'am, are you with us? Sabita, ma'am, can you see Lulu, madam?
I can't actually.
Maybe we lost her.
I think we did. I'll just call.
Ma'am, you mute. Ma'am, mute ആണ്. ഇപ്പം വിനീല
I mean, my screen visible now. Ilyas, please.
It's visible.
I'll stop this. Can you do the screen sharing? I'll talk from here. Okay? Ilyas. Eh?
Ila?
No. Vinila, you should not share. Vinila, please stop screen sharing from your side. Ilyas will do it.
Okay, ma'am, I have stopped.
Yeah.
Ma'am, is it visible now?
Yeah. Is it visible now to the others?
Yes, ma'am, it is.
Yeah. Ilyas, a slideshow leader. Oh, no. Okay. So Manjari has given a foundation. So I can just build upon it. And very basic practical things only I will be telling you in this session. Next slide. Yeah. So I bring you greetings from IPM. I am working in Institute of Palliative Medicine, Kozhikode. But right now I am in Lakkadi, Wayanad, and heavy rains, and that is why the connectivity is rather poor. So my colleague, Mr. Ilyas, is screen sharing from IPM. Next slide. Okay, so what more can I say? A little bit about communication, very little, just a glancing. The terms to be avoided.
Lulu ma'am, maybe you can just turn off your video because there's a lag in the connectivity, if you don't mind.
Okay. And I will be ending up with a case history. Next slide, Ilyas.
Ma'am, there is an
See, when
issue
you
with the
communicate,
voice.
am I audible?
Ma'am,
Am
there's
I
a small issue with the
audible?
voice.
Voice is breaking.
Voice is breaking.
Yeah.
It is okay. It is okay.
Okay. So when you communicate with children, you don't think that, you can guess things as you do with adults. You will never be able to guess what the children are going to tell you. I'll give you an example. Next slide. Next slide. Yeah, this is a girl, 8-year-old girl, who was posted, who had an osteogenic sarcoma. And she was posted for amputation. So she was sent to our center. And then when we talked to her, we asked her, so many things, and we asked her, next week you are going to a surgery. Yes, I know. Are you worried? Then she said, yes, I am. So hearing that, we were also worried. What could be the cause of our worry? 1 or 2 guesses, please. 1 or 2 guesses.
Not able to walk.
Not
Amputation.
able to walk. Good. Anything else? One more.
Pain
One
of
more
surgery.
guess.
Pain of
Pain.
surgery.
Okay. But you know
Not
what
able
she
to
said?
play. Not
Play
able
with
to play.
Okay. Next
And
slide.
disfigurement.
Next, Ilyas. What she
About the
said was,
marriage.
what she
About
said
her
was,
marriage.
where will I wear my anklets now? See, that is something which we never considered at all. Where will I wear my anklets now? That was what was worrying her. So now, we can talk to her about that, about the fees. Where so treatment, and then preparing, and she will be in a better frame of mind. That's why I told we will never be able to guess what we are going to say. So don't ever, when you communicate with children, never ever guess. You listen to them. You listen to them, and then as pediatricians, because we have an MD or an MRC PED, even read their minds. Next slide. Immunization in kids. So this site, government hospital, the mother, a beaming mother, she's happy because, at last reached the important seat. So far she was standing in a queue, and now she has come to the seat. So she's very happy. And the child there, the baby is also with her. Now you see, as soon as the prick is made, this baby will start to howl. Then what happens? Next slide, Ilyas. Next slide. Yeah, another howl. So you see a series of howls coming one after another. And then you see the mother. She's very anxious. My God, what is happening to my child? She's very, very And then the next slide. After some time, she might even, shout at you. Okay, why? All of this is because you know, a series of children howling and crying and making all sorts of sounds. So you see, what you see here is a child-friendly immunization clinic, something which is seen in Western countries. Some of you will be maybe working in hi-fi, Wi-Fi hospitals. So why don't you consider setting up a child-friendly immunization clinic? You see, something not much like this, but something like this, you know, a very friendly room where the mother and the child will feel very comfortable, and the child may not realize the full extent of the pain. Next slide. So, you know, the immunization, painful procedure. So what can we do? Let us start at the very beginning. Okay, next slide. Okay, a very good place to start. When you read, you begin with A, B, C. When you sing, you begin with Do, Re, Mi. And when you start inflicting pain on children, where do you begin with? Any guesses? Inflicting pain on children, where do you begin with? Anybody? Inflicting pain on children. Pankaj, if you are going to say, yeah. What's it?
Talking to them.
Next slide. Ilyas, next slide. You begin with immunization. That is the first painful procedure for any child. Any child. It is not just injection, because it's a normal child, will go home without any pricks. But immunization is the first, a painful procedure which you inflict on children. So what can we do about it? Next slide. See the 4 P's of pain management in immunization: pharmacological, physical, psychological, and procedural. Next slide. Pharmacological, you can apply some topical anesthetics before giving the prick. You can give sugar water to the child. That will definitely help in easing the pain. Next slide. Physical. So hold the baby upright, close to the mother's chest or breast. And if it's an older child, make the child sit on the father's or mother's lap. And if it's a newborn baby, allow the mother to breastfeed the baby. These are certain physical procedures which you can do to help relieve the pain. Next slide. Psychological. You can distract the baby's attention with a rattle. Okay. And if it's an older child, you can give her a toy to play with or a book to read. And if she's an adolescent, you can ask her to take deep breaths. So your attention will be diverted, and that will help in relieving the pain to some extent. Next slide. Procedural. See, rapid intramuscular injection without aspiration. Okay. And secondly, several pricks are given simultaneously. So give the most painful prick as the last. So these are the 4 P's in relieving or lessening the pain in immunization. Next slide. And again, see, gruesome circumcision. Even now in different parts of India, this is done in local anesthesia. And believe me, circumcision is being done in the most sensitive area of the baby's skin. So you should see that no baby undergoes circumcision in local anesthesia. It should be done under GA. And please use your, influence in making the parents, your neighbors, your relatives, your cousins, to do the circumcision under GA. Next slide. See the child who is howling and screaming, local anesthesia. This is the baby with general anesthesia. So see that circumcision is done in GA. Next slide. When I asked about a painful procedure inflicted on babies for the first time, you talked about injection. Okay, we give such sort of intravenous injections also. So before pricking, why don't you start using amla cream, which is now free, which is now available? I agree it is costly, but still, if you are able to apply amla, wait for some time, and then give the then try getting at the vein. It will definitely help in relieving the pain. Next slide. Now, see, you people think only adults have autonomy. This is about a child, Alex. He was 15 and he had a huge, very huge tumor on the neck, sarcomatous tumor, huge one. So that, he could not even hold his head erect. And when he came, 16-year-old boy, adolescent. So, I mean, we always, adolescents are the toughest group. Very, very difficult to manage them. And, he was very fond of using his phone. So any medicine you prescribe, he will ask, what is the name of the medicine? And he used to look it up and then talk to us about the side effects. Am I going to get the side effects? Sometimes, you will get angry. Why? But you should not, because that is his autonomy, He wants to know everything about the medicine, which is being and then what happened. And one day the tumor started to bleed, and we knew that was the end of his So we were very cautious. We tried to stop the bleeding, and as very trickling, but we knew. And then suddenly he said, I would like to, he was a Christian, I would like to, can you get a priest for me? So we sent for a priest from the nearest church, and the priest came. They had a sort of, sometimes a priest prayed for some time, and then this Alex told, I want to confess. I want to confess. We all went out. We had a good confession. And at the end of it, he looked very calm, very peaceful. And 2 days later, he passed away.
Ma'am? Lulu,
I think we lost ma'am again. Meanwhile, Savita ma'am, until madam joins, would you like to read out some questions in the chat so that maybe Dr. Manjari can...
No, let me finish the talk.
Okay.
Let me finish the session. Okay. Next slide. Okay. Children know they are dying. Again, any guesses from your side? Do they know they are dying? This is a 5-year-old, 6-year-old child, I think. Yeah. Do they know they are dying? What is your guess? What's your guess? Come on.
No.
Any guess?
Unlikely.
No.
No.
Yes.
They know.
Likely. Yeah.
At times they know.
Yes.
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 They know. Okay. Next slide. Next slide. Yeah. This is, he's 7-year-old Afsal. You know what he used to tell? He never used the word death, but he said, I cannot become a doctor, but my brother will become a doctor. He will be a pediatrician who will look after kids without taking consultation fees. We were surprised. We asked, why like that? So the mother, what she told us? She used to take Afsal to a nearby pediatrician. And even if she went on alternate days, that doctor used to take consultation fees. And Afsal never said anything to the mother then. Coming to the hospital, when he was talking about the impending death, he said, my brother will become a pediatrician. I will not. And he will become a doctor who will not take consultation fees. So you see, that is the way children think. Okay, next slide. Next slide. Okay, Ayana. Now this Ayana. Next slide. Next. Yeah, this is a 3.5-year-old child with neuroblastoma. You know, often she used to say, don't cry, Amma. She would stroke her mother's cheeks. Don't cry. I will not die. I will not go away. I will come back as Kunyava. Kunyava in Malayalam means small baby. So you see, she was giving hope to her mother. And what was she telling? I will not go away. I will come back as your Kunyava. So what did she mean by that? Actually, what? I mean, did she know that she was going to die? And that she was speaking, I will come back again. And she was less than 4 years old. And she loved color, you know. So she used to always wear pink nail polish. And when she died, her mother had bought for her a pink.
Ma'am, we are unable to hear you. We've lost her again.
We are muted.
Shall we wait? Just try and contact
Yeah.
Dr. Lulu and then
Yeah.
if she's
1 year
back.
after
Yes.
her death, 1 year after her death, her mother informed us she was pregnant. And 10 months later, she again called back and told us she has had a baby boy whom she has named Ayan. This girl was Ayana and her baby brother Ayan. So actually, Ayana has come back as her mother's kunyava in the form of Ayan. So you see, she also knew she would leave her mother and go away. Okay, next slide. So this is what, you know, in spirituality in children is quite different from spirituality in children. We might give medication to a child considering physical pain, but it could be spiritual pain. And only thing, the spiritual concerns are in the form of love for parents, hope, legacy. You see, what that is what Ayana was talking about. I will come back as your Kunyava, forgiveness, safety. These are all the things which come into the purview of spirituality when you talk about spirituality in children. Next slide. Okay, will Amma forget about me after some time? This was Robert's doubt. Robert was a 10-year-old boy. So his worry was, after some, I know I'm going to die, but will my mother forget about me? And you know what he used to say? I want to live again with you. Amma, will you come down into the grave with me? See, that is what Robert used to say. And he say, some others, you know, they talk about, they say, I want to have my brother with me. I want to have my sister with me. Or I want to have my pet dog with me. What does that all mean? It shows, you know, they all have a foresight that they are going to leave us all. And then again, talking about magical figures. Sometimes, you know, they talk about Spider-Man, and Spider-Man will come and take away my illness. So they, because they believe in such magical figures. Next slide. Rishna. Rishna is a 9-year-old girl who has brain tumor. And clinging to her mother, she used to say, I'm frightened to die. Be with me. Do not leave me. And you know, this mother was a single mother. And actually, their neighbor, there was a neighbor, and he also used to come to our hospice to see. So this Rishna, he requested this fellow to marry her mother. And you know what Rishna told? See, when once I go away, my mother will be alone. So you have to give her company. 9-year-old girl, I'm sure you are all thinking I am bluffing, but none of this is bluffing. This is exactly what happened in IPM in case of various children. And these are all children whom we have managed. Okay, so, and this uncle had brought her a Bermuda. And Rishna said, I mean, I love this Bermuda. And when she died in IPM, she wore this Bermuda when she went home. And imagine a 9-year-old girl requesting her mother's friend that he should marry her to give company to her mother. Next slide. Okay, so it's a spiritual dialogue. How do you know that a child is having spiritual distress? I mean, listen to the words like God, heaven, spirit, hope, sad, ghost, afraid. Okay, these are some of the words. And then again, listen to the dreams, what the dream means to the child. Do not try to explain the dream. Just tell them to talk to you about what he or she thinks about the dream he or she has had. Listen for searching phrases like, that shows the child is thinking. I wish, I wonder, statements like that. Listen to the journey. Sometimes the child says, talking about going home, leaving IPM, leaving you all. Don't give any false reassurances. Don't think these children are fools. No, don't ever talk to them like that. They know what they're talking about. You just have to go with the child. Next slide. Okay, this is something very, very important. You see, because as pediatricians, we see a lot of children whom we just term as MR. That's the old word MR, has such a negative connotation. It's no longer used. See, what is the difference between palliative care and the conventional medical care? Palliative care, we care not only for the child, but also for the child's family. We care for the child's parents. So we don't want to make the parents unhappy. So this is actually the retard is a slang, very slang term, and it is often used to put people down. And it is simply insensitive, simply insensitive. So pediatricians, please don't use the terminology mental retardation. Okay, when you talk to parents. Next slide. Children with intellectual deficiency, that's a very sober term, have significant difficulties. They have difficulties in both intellectual functioning, like communication, learning, problem solving, and also, next slide, day-to-day activities. Okay. And in adaptive behavior also, everyday social skills, routine, hygiene. These are all the problems which these children have. They do have problems. Next slide. But don't add problem to their friends. Calling these children mentally retarded. Okay. So mentally handicapped child is not able to learn or develop skill at the same rate as most other people, because they have a problem with the brain.
Dr. Lulu?
Let the screen sharing come. Elias.
Ma'am, is it visible? Ma'am, you're muted.
Illa, no, it's not visible. It's not visible. Yeah. Okay. Okay. So why don't you talk something like this? Okay. Your child's brain is not going at the same rate because they have some problem with their brain, something like that, but not mentally retarded. Next slide. Next slide. You see, this child, and we know it's a Down syndrome child, but don't tell that your child is mentally retarded. You should not. You should not.
Lulu ma'am? Not able to hear you. Madam?
Let the screen sharing start.
We can see the screen. Can you see it?
No, I cannot. Okay, then let me take the, I don't know which is the slide which is being projected.
Child with the mother and child with the trisomy.
Down
Wait,
syndrome.
Yeah,
Child
yeah,
with the
yeah.
Down syndrome.
Okay, okay. Yeah. So suppose when the mother comes, you're telling, okay, your child is mentally retarded. What happens then? Next slide. Yeah, see, for children, for parents, you know, their children are almost like the sun. Sun is everything for us. Just like that. And when you hear that your child is mentally retarded, what happens? Next slide. Next slide. The sun has set. The sun has set. So, how can you break the news? Don't ever say your child has mental retardation. Next slide. So your child has intellectual disability. Seconds only needed to say those words. Okay. But if you use the first sentence, the parent's sun has set. Okay. The whole world has changed for the family. And often you see the time immediately after the diagnosis is very simultaneous one. And added to that, you are also increasing the parents' anxiety and sorrow. There are many typical feelings, you know, including fear, confusion, anger, everything happening in parents at one setting. Next slide. So some parents take a while coming to terms with that diagnosis. Other parents feel relieved that they finally have an answer. So what does that mean? Don't give the wrong diagnosis, but give the diagnosis in a very soft manner. Don't ever use the word mental retardation. That's what I want to convey. Next slide. Our dreams for a child may alter. This is straight from a parent. But I can assure you, they can and will achieve more than we may have hoped possible. It begins with love growing into experience and accountability. Parenting journey brings more gifts you can imagine. So this is exactly what a parent had to say. And she does not say, don't tell me what's going to happen to my child. But it's a manner in which you put across. That's what is much more important. Next slide. So Ramu, 2 years old, okay, and without age-appropriate developmental milestone, bedridden, totally dependent on others for all activities of life. Is up to you. Next slide. Next slide. What is the story of Ramu? He was developing normally, then starts losing the acquired milestones. Next slide. Yeah, see, neck is erect. Sitting, starting to walk, and then suddenly regression. Okay, next slide. Again, you tell them your child has a previous slide. Previous slide. Yeah, this is my slide. What is that? What I'm trying to convey? You are talking to the parents. Your child is mentally retarded, neurodegenerative disease. This is what happens. Their life is in total darkness. The sun is set for them. So again, there is a manner in which to break the news. Next slide. Okay, a bedridden child. What can you do for that child? Next slide. Don't ever tell them nothing more can be done. You can give them drugs. You can give them rectal anticonvulsants, tube changing, respite care. So many things you can do for this child to make the parent's life more comfortable. Next slide. Okay. So next slide. See, a simple thing, using a soft toothbrush. See, this is a sada brush. You remove the bristles, wrap cotton roll around the, next slide. Now it is like this. Next slide. Next. Yeah. See, wrapping a cotton gauze. Previous slide. Yeah. See, and tie the lower portion. Now it has become a soft brush. Okay, it's a soft brush. And you know, this is something very simple. I mean, nobody ever, you talk about the newer anticonvulsants, but you don't consider such small things. Next slide. This is a child with neurodegenerative problem. See how lovingly the parents are taking care of the child and advising small things like making use of a soft brush, listening, make the child listen to music. Things like that, you know, will make the parents happy too. Next slide. Okay, what is respite care? Providing parents and other caregivers with short-term childcare services, offering temporary relief. Why? To improve the family's stability. Okay, next slide. You will understand. Next slide. This is a child with a neurodegenerative disorder, you know. Previous slide. Okay. So this is, you are allowing the mother, the parents, and the mother and the child to be admitted in your hospice. Normally you think nothing can be done. No, see, mother is with the child 24/7. So the mother needs some rest. The mother needs some rest. Please mute, Sabida. Okay. So the mother needs some rest. So let the mother and child come to your hospice and spend some time there. Next slide. Yeah, these are other instances, you see, where you allow mother and the child to come to the hospice, and in IPM, we allow paraplegics and such, even 4 times a year, they can come and spend time for about 2 to 3 weeks at a time. This is known as respite care. Next slide. Next slide. Okay. And when you talk about symptom management, please consider sleeplessness also as a symptom. Okay, the parents will say, not sleeping at night. Night is the only time when the mother can sleep. So please, when a mother complains of sleeplessness, consider that also as a symptom. Next slide. Okay, post-head trauma. See the child. Okay, all sorts of tubes around. And then you are telling nothing more can be done. Take the child home. Next slide. And then not much change, but the child has opened the eyes. That is enough for the parents to be happy about something. Okay, so don't tell them, take away your child, nothing more can be done. Don't ever. Next slide. Okay, so a remedy which is known to work, though nobody knows why, is preferable to a remedy which has the support of theory without the confirmation of practice. What does that mean? A remedy which is known to work, though nobody knows why. A child is telling, my mother massages my abdomen, my pain is gone. Okay, we don't know how it works. Preferable to a remedy which has the support of theory. Morphine is supposed to relieve the mother's child's tummy pain, but it is not. So this is very, very important. Sense of Asher, very, very important in children's palliative care. Next slide. The goal is to add life to the child's years and not simply to add years to a child's life. I hope you know the difference. Next slide. Okay, you see here, again, this is a child, you know, a dysmorphic child. But you see, a child's birthday is celebrated here. New frock, candles, cake. See, these are all things which make the parents very happy. And we don't know whether the child is also being made happy. So don't think that just because a child has some intellectual disability or it's a dysmorphic child, you don't need to celebrate the child's birthdays. Next slide. Okay, again, don't think only cancer needs palliative care. This is a girl who is having diabetes mellitus. Okay, diabetes mellitus, idiopathic. And then she grew up, she was our patient, she got married, and she came to visit with her baby also. Okay, and now she has 2 children. So all chronic conditions should be brought under the purview of pediatric palliative care. Right? Next slide. Okay. So this is, I told you, I'm ending with case history. A 10-year-old boy, vehicular accident brought to IPM. This was the stage in which he was brought to us. This was the stage. Next slide. You see? Next slide. So this is the boy. Okay. This is the boy here. A school-going child, 10-year-old boy. They were both walking to the school when a jeep hit them, and he fell down, and he was brought to us months later in the picture which I showed you. Next slide. Okay. Next slide. Next. So this was the child who went to school, and this was how he was brought to us in November 2019. Next slide. So they were told nothing more can be done. And this was the picture taken in the previous hospital. You see, the hands are tied. And the parents brought, somebody referred the boy to IPM. Next slide. So we told, bring all, his name was Achu. His proper name was Martin, but he had a pet name Achu. So we said, bring all of Achu's toys. So they were all brought and arranged on windowsill. Next slide. So this was a favorite toy, Android Kunyapan. Android Kunyapan is also the name of a movie, Malayalam movie, you know, and this toy is also based on that. That was Achu's favorite toy. So that used to be kept on his bed, and that they used to talk and move around. We were doing things to give stimulation to his brain. That is what we're doing. Like, I hope you see the chicks come out, and here also some flesh. Next slide. Yeah. The boy who came to us like this, okay, 1 month later, you see the difference, okay? And then, next slide, next. Okay, so music round the clock. His mobile is here, and always it used to play round the clock. His favorite songs, his favorite songs. Next slide. Yeah. Then we thought, you know, let us make use of his siblings. There were 3 of them, and he was the middle one. We knew he had 2 siblings. So we told the parents, you bring the siblings to the hospital. Next slide. Yeah, you see the day the younger sibling walked into the hospital, called choose him. This was the response from him. This was the response. That's the power of sibship. Next slide. And you know, we were trying out all sorts to stimulate this flashing lights, hanging toys, agarbatti, music, and very positive. Mother. Always she used to keep the boy very interested and, you know, very, as far as possible, wakeful. Next slide. Next slide. You see the difference. November 2019, and this is January 2020. 2 months. Next slide. Now you see, we got a physiotherapist help and being made to sit up, and here now he is able to sit with the head unsupported. Okay, so these are all the physiotherapy tech. Next slide. And we used to, the mother used to take him out in the IPM on a wheelchair. And this is, you see, he used to, I mean, he seemed to enjoy these rounds. Every day the mother used to take him round in a wheelchair. Next slide. Next. So this is January 2020. This is March 2020. See, he is able to sit up now. Next slide. This was the picture in November 2019. Next slide. Okay. Okay, one more. See now, this is November 2019. This is 2020. I mean, this is mid 2020. This is taken at home, their home. And this is 2020. And see the difference. This is the boy who came to us in November 2019. 1 year later, this is the picture. Next slide. So this is the latest pictures, which the mother, we got from the mother about 3 months back. So from nothing more can be done. A lot could be done. I'm not telling that, he's pakka the original Achu he was. But still, I'm sure, I mean, so bad to see a child who came to us in the situation of November 2019. But definitely the parents will be much more happier now. Next slide. So now I want to talk to you. Please don't imprison your children with terminally ill children in the ICUs. Okay. You provide them with a colorful end of life room. Colorful in all respects. With bright curtains, good flowers, music round the clock, toys. Enable the parents to be with the child. Don't ever imprison children in ICU, because you know very well that they're not going to live long. At least let them have a good time with their parents. Next slide. Last one. So you should remember, children are born with rainbows in their hearts. You will never reach the children unless you reckon the rainbows. You have to reckon the rainbows. Next slide. And if any one of you has the habit of reading, I would advise you to read this book by Imran Hashmi, Kiss of Life. This is about his son, Ayan, who was diagnosed with Wilms tumor when he was 3 years old, and how Imran Hashmi has lived his life for his son. It's a very good book. You read this. And if Imran Hashmi could do so much, I'm sure we as pediatricians should be able to do much more. How did he do this, Imran Hashmi? Because he was able to reckon the rainbow in his son's life. That is it. Next slide. Yeah. So that is it. I have come to an end. Yeah.
Thank you very much, Dr.
I'm
Lulu.
very sorry. We are having terrible rain here, So that is why the connectivity is rather poor. And I had to make Ilya screen share it from IPM.
That's okay, ma'am. We were very much encouraged and inspired by what you shared, and you opened out a window into a child's mind and emotions and what they think about death and so many aspects of palliative care. Very relevant for us, and it makes us look forward to the next sessions to learn more. So in interest of time, I'm just going to read out some questions from the chat, which Lulu ma'am and Manjri ma'am, please would you take. The first question is from Dr. Naresh regarding palliative care. Dr. Naresh, are you here? Would you like to ask your question?
Just read out the question.
Okay, so he had talked about palliative care is not just taking care of pain, and he wanted to know how broad the aspect of palliative care is, and whether it is only for chronic conditions or for even acute infections.
See, it is mainly talk about chronic conditions. Acute conditions, we have treatment, we can manage them. But acute conditions, it is most important is proper pain management. That is it, proper pain management. That's the most important thing. Very often when a child has to undergo a surgery, we think, oh, surgery means pain, that the child will suffer. It is not like that. Pain should be properly managed. An acute condition, proper symptom management is the most needed thing. But in chronic conditions, it touches upon so many. I mean, I told you the ethical principles are involved, spirituality is involved, the concept of total pain is involved, taking care of the parents, taking care of the siblings. So many things are involved.
Thank
So
you, ma'am.
I'm going to
Anything.
add a little bit to that,
Yes.
Sabita, if I may.
Sure.
So I think here's the question, the perspective is, why would a child with an acute infection need palliative care? Now, I have a lot of kids who actually have acute infections, and because they are mostly long-term ventilation bound, these are very severe septicemias or ventilator associated pneumonias. So are we talking potentially about a severe infection that could be a threat to the child's life? Well, there's a good chance of recovery, but in the here and now, maybe difficult decisions need to be made. Should the child be in ICU? Should he have dialysis? So that's a time where a palliative care team can, be an additional layer of support. And if the child recovers, then, there's that opportunity to withdraw palliative care. So I go with a potential threat to life or what is life shortening. The child might make a complete recovery, and that's fantastic. But yeah, definitely, I think for serious, infections, there is a chance for palliative care to be involved.
Thank you to Dr. Manjari. Another question from Dr. Bhavna was, how do we introduce palliative care to the family? I work with a lot of complex needs patients and find it the most difficult topic to broach.
So thank you for that question, Dr. Bhavna. In fact, I had a slide saying, what are some of the words you could use? It might be to say that here's a team that can help you, think about what you've understood about the disease condition and what lies ahead. Here's a team that could help with some pain and symptom management. Here's a team that could help you think about how you could take your child home. Or it could just be that, palliative care is a part of routine care that's offered at our institution. So these are some of the things. And we are not the grim reapers, and sometimes it might be that the best thing is to bring the play person in, or, the music person in, rather than rolling out the guns with a physician and a nurse coming in. So there are a number of creative ways to do this.
Thank you, Dr. Manjari. I'm sure we'll be learning more also during communication sessions. Dr. Zeenath wanted to know how sugar water helps in reducing pain.
What's that?
Sucrose for neonates to help in reducing pain. I think it's mainly through the endogenous opioids when you give sucrose. I will take one more question I'd like to address is, in the WHO definition, palliative care is for life-threatening illness, while palliative care should be for any illness with suffering, maybe not even life-limiting. Any comments about that? This is from Dr. Jagdish Chinnappa.
I'm just going to say thank you, Dr. Jagdish. I mean, you pretty much have got the gist of it. So I think anything that could be too much suffering, yes. And in India, it could be something like, very prolonged NICU stay, uncertain prognosis, and absolute complete financial devastation of a family. What does that look like? And that's real suffering. So suffering is not just physical. It could be a bunch of things. And so, yes, definitely that additional layer of support could help.
What I would like to add something. See, even in handing over chronic cases for palliative care, the hospital authorities and the pediatricians are not in favor. So if you jump into acute conditions now itself, I think, we may not achieve more. So first, let us tackle the chronic conditions and let us get into their confidence and let them know that we can do something for them. And then I think we can slowly enter the field of acute problems also. Otherwise, now itself, you ask anybody working in palliative care, I mean, the hospital authorities, the consultant, they're all very hesitant to pass on their patients for palliative care. So my thing would be, let us first stick on to chronic cases, terminally ill cases, and then gradually things will improve, and then we can get into acute stage.
Thank you, ma'am. There's a lot of awareness that can be built up about palliative care and the broad scope of it in the future. I can take one more question. Is there anyone who's got a question that has not been answered? If not, we're coming to the close of our session. Okay. Right. Thank you so much, Dr. Lulu and Dr. Manjari, for your didactic sessions. They were very informative, and I know it's given us an appetite for all the sessions to come and to learn more. To all the participants, those of you who are not able to do the pre-test, please don't worry. Your post-test will be in your emails soon, and you can answer them. And any queries, of course, you can direct to to Mrs. Vinila regarding the tests. For our next session, please do remember to name and label your phone so that we know who is there for attendance sake. And also, again, there will be a pre-test and a post-test. And if you are able to complete it, you don't have to say that you're completed on the chat. We will understand that it's been done. So we can proceed without any interruptions. So we would like to welcome you back for the next session, which will be on.
Is there any time limit to submit the post-test?
Vanilla?
If possible, it will be nice if you submit it the same day, ma'am. I'll be sending the link shortly, immediately after this session.
Okay, thank you.
Okay, so same day. It won't take long. So next session, next Saturday, 12th of August at 3 p.m. And our topic will be chronic persistent pain in children. Thank you all for attending the session, and we'll see you all next week.
Thank you, everyone. And thank you, Sabita ma'am, for facilitating the entire session. Thanks a lot.